Welcome to the deep dive. Today we're taking on a really vital topic, geriatric psychiatry. We'll be distilling the key concepts and challenges right from leading clinical sources. And the mission here is pretty urgent. We're facing a huge demographic wave. Get this. The number of older adults with mental illness is set to jump by, well, a massive 275% between 1970 and 2030.
Yeah, that's from about 4 million up to 15 million people. It's staggering.
That growth rate is just completely outpacing younger groups.
It really is. And there are a couple of big societal factors driving that. First, there's what some call the longevity gap.
Okay.
So people with serious mental illnesses like schizophrenia, they historically died much younger. They didn't always get the benefits of general health advances.
Oh, I see.
But that gap is closing. So more people with serious conditions are living into older age. And second, you have the baby boomers.
Right. Huge cohort.
Exactly. And this generation, they're expected to have higher rates of things like depression, anxiety, and substance use issues than previous generations entering late life.
So increased longevity for the seriously ill, plus a larger, higher risk group getting older. That sounds like a perfect storm for healthcare systems.
It presents an unprecedented challenge, definitely.
It does. But, before we dive deep into the problems and the pathology, I think it's important we touch on the positive side, the idea that aging is just decline.
Mm-hmm.
It's not the whole story, is it?
Not at all. And the sources really emphasize this. Psychological well-being, happiness generally, it often actually increases after middle age.
Increases, really?
Yes. People talk about a U-shaped curve. Contentment might dip during the midlife crunch, peak responsibilities, but then it tends to climb back up again. We often get happier as we get older.
That's fascinating. And is that linked to this idea of wisdom that comes up?
It often is. And wisdom here isn't just about knowing facts. It's defined by specific things like prosocial behaviors, empathy, compassion, also emotional regulation, managing your feelings effectively, self-reflection, being able to accept different viewpoints, even conflicting ones, decisiveness too, and maybe a spiritual component for some.
So it's quite multifaceted.
Very. And crucially, higher levels of this kind of wisdom, they correlate strongly with greater happiness, resilience, and importantly, better physical health outcomes.
Which changes how we think about successful aging. The old models like Rowe and Kahn were pretty rigid, right? Like no disease, high function, stay busy.
Exactly. Very demanding criteria. And it kind of excludes anyone living with chronic conditions, which is most older adults, frankly.
So what's the alternative view?
Well, what's interesting is when you ask older adults themselves how they define successful aging, they focus much more on psychological factors, things like adaptation, acceptance, emotional well-being.
Things you can actually modify, maybe?
Precisely. It's less about the absence of physical problems and more about the capacity to adapt to whatever life throws at you. And that ability to adapt is key when we start talking about assessment and treatment later on.
Okay, that makes sense. That emphasis on adaptation leads us nicely into assessment, which sounds incredibly complex in this age group.
What's the biggest hurdle clinicians face?
Oh, hands down, it has to be polypharmacy.
Meaning, too many medications.
Exactly. Older adults taking multiple drugs, often from different prescribers, getting a complete, accurate list of everything they're taking, prescriptions, over-the-counter, supplements, is absolutely step one.
Why is that so critical?
Because very often, cognitive issues, mood changes, confusion, they can actually improve significantly just by stopping an inappropriate medication or adjusting a dose. You have to rule out drug effects first.
So before even thinking about a psychiatric diagnosis, you look at the meds.
You have to. We need to be especially vigilant about what's called the anticholinergic burden.
Anticholinergic. Sounds complicated. It just means drugs that block a certain neurotransmitter, acetylcholine. Many common drugs have this effect. Some allergy meds, bladder drugs, older antidepressants, and these effects stack up.
Like additively.
Yes. And that combined burden can cause confusion, memory problems, even urinary retention, mimicking dementia or depression.
Wow. Okay, so medication review is paramount. Then what? Cognitive screening.
Absolutely essential. Tools like the Mini Mental State Exam, the MMSE, or the Montreal Cognitive Assessment, the MOCA, are standard.
But I gather they're not perfect.
No screening pool is. A really important point is that low educational attainment can artificially lower scores on these tests. Someone might seem impaired just because they didn't have much schooling, not because they have dementia.
So clinicians need to factor that in.
Definitely. And another key thing, just basic but vital, how you introduce the test. You need to ease anxiety. Tell the patient some of these questions are easy, some are harder, so they don't feel stressed if they stumble on an item. It builds rapport.
Good point. Beyond those standard screens, the sources mention mapping out the family history.
Yes, the genogram. It's basically a family tree, but specifically mapping out relationships and, crucially, psychiatric or neurological conditions across generations.
Like Alzheimer's or Parkinson's.
Exactly. Or schizophrenia, major depression, bipolar disorder. It gives you immediate context about potential genetic predispositions or family dynamics. It's a really useful tool.
Okay. And what about assessing mood? You mentioned depression might look different.
It often does. It frequently goes undiagnosed. Patients might deny feeling sad, maybe due to stigma, or they just think feeling down is normal for getting older.
So how does it show up then?
Often through somatization, they focus on physical complaints. Things like chronic pain, constant fatigue, low energy, digestive issues like constipation. The emotional distress is expressed physically.
So the clinician needs to probe beyond the physical symptoms.
Very carefully, yes. Asking about enjoyment, interest, energy levels, not just, are you sad?
Got it. Now, let's talk function. This seems like a critical line, especially for diagnosing dementia.
It is the critical line. A diagnosis of major neurocognitive disorder, what people usually call dementia, requires cognitive deficits severe enough to interfere with independence in daily life.
So it's not just about memory scores, it's about whether they can manage day to day.
Exactly. Can they handle finances, manage medications, drive safely, cook a meal? That interference is key.
How do you measure that interference?
We use specific tools. The Functional Activities Questionnaire, or FAQ, is common. It's a quick 10-item list asking the patient or an informant, like a family member, about difficulties with those everyday tasks.
Okay.
And we also use brief performance tests, like the timed up and go test or TOYUG. You just time how long it takes someone to stand up from a chair, walk 10 feet, turn around, walk back, and sit down.
Seems simple.
It is, but it's surprisingly powerful.
Yeah.
That time predicts risk for falls, hospitalization, even mortality. There are others, too, like the Short Physical Performance Battery, SPPB. They give objective data on physical function, which is closely linked to cognitive function in older adults.
Okay, assessment is clearly a minefield. How do the actual psychiatric conditions present differently then? Let's start with depression and dementia. You said they're intertwined.
Deeply. The rate of depression in people who already have Alzheimer's disease is really high figures, range from 5% up to nearly 50% in some studies.
Wow, almost half.
And maybe even more importantly, having a history of major depression earlier in life might actually double your risk of developing dementia later on.
Double the risk. That's significant.
It is. There's a concept called the DED hypothesis, depression executive dysfunction. It suggests that late-life depression, the kind that starts in older age, might be linked to changes in the brain's frontal limbic circuits, the areas controlling executive functions like planning and organization, and these changes overlap with those seen in early dementia.
So depression might be an early sign or even a risk factor. What about anxiety? I was surprised to read that anxiety disorders are actually more common than major depression in older adults.
That's right. It often surprises people. This includes things like generalized anxiety, panic, phobias, PTSD, OCD-related disorders. They're very prevalent.
Are there specific anxiety syndromes we should know about in this group?
Yes, a couple stand out. Hoarding disorder, which is now its own diagnosis, seems to be about 3 times more common in older adults compared to younger people. It can cause significant safety risks, obviously.
Right, falls, fire hazards.
Exactly. And another one, often missed or dismissed, is fear of falling. Around a quarter of older adults living in the community report this fear.
Just a general fear.
It can become a specific phobia. And the irony is the fear makes them restrict their activities, they become less mobile, weaker, which actually increases their risk of falling. It's a vicious cycle.
That makes sense. Okay, let's shift to something acute. Delirium. That's the sudden confusion state, right? A medical emergency.
Absolutely a medical emergency. It's different from dementia. Delirium is defined by fluctuating levels of consciousness, problems with attention, and usually memory impairment.
Fluctuating is the key word.
It's critical. A patient might be lucid one moment and very confused the next. If you only see them when they're lucid, you miss the diagnosis entirely. That's why communication across shifts between nurses and doctors is so vital.
And what causes it? Is it often medications again?
Very often. We call them deliriogenic medications. Common culprits include certain opioids. Meperidine is a classic example. Strong anticholinergic drugs, like some tricyclic antidepressants or oxybutynin for bladder issues, and some long-acting benzodiazepines like diazepam. They can easily tip an older brain into confusion.
So again, check the meds. Finally, psychosis in dementia. The statistic you mentioned earlier, up to 62% in nursing homes. That's incredibly high. How do clinicians manage that, given the risks of antipsychotic drugs?
That's the huge dilemma. There's an FDA black box warning on all antipsychotics, both the older ones and the newer ones, like risperidone, olanzapine, quetiapine.
A warning about what?
Increased risk of death in elderly patients with dementia-related psychosis, mainly from things like stroke or heart issues. So using these drugs to treat agitation, aggression, or hallucinations is a serious calculation of risk versus benefit.
When would you use them then?
Generally, only when the psychotic symptoms or agitation pose a significant risk of harm to the patient or to others, and non-drug approaches haven't worked. It requires very careful consideration and documentation.
This all highlights the complexity of treatment. If we have to be so careful with drugs, what's the guiding principle for geriatric pharmacology?
The absolute mantra is start low, go slow, but go.
Meaning?
Start with a very low dose, increase it very gradually, but don't give up too early.
Mm-hmm.
Go high enough, eventually, to get a therapeutic effect if needed. You have to remember, older adults often have slower metabolism and excretion due to kidney and liver changes.
Right, and drug interactions are a major concern.
Huge. We talked about anticholinergic burden.
Yeah.
Another big issue is the CYP enzyme system in the liver, which metabolizes most drugs. For example, common SSRIs like fluoxetine and paroxetine strongly inhibit an enzyme called CYP450-2D6.
And that matters because
That enzyme also breaks down many other drugs, some beta blockers, some antipsychotics, pain meds. So if you add fluoxetine, the levels of those other drugs can shoot up, causing toxicity. You really need to know these interactions.
Okay, focusing specifically on dementia treatment, what's the basis for the drugs we currently use?
Well, there are two main hypotheses driving current treatments. The cholinergic hypothesis suggests that memory and cognitive problems are partly due to a deficit in the neurotransmitter acetylcholine.
So the drugs boost acetylcholine.
Exactly. That's what the cholinesterase inhibitors, donepezil, rivastigmine, galantamine do. They slow the breakdown of acetylcholine. Then there's memantine, which works on a different system, the NMDA receptor. These are symptomatic treatments.
They help symptoms but don't stop the disease.
Correct. The other major idea is the amyloid cascade hypothesis. This focuses on the buildup of beta amyloid protein plaques in the brain as the primary driver of Alzheimer's disease.
And that's where most research is headed.
Overwhelmingly, about 80% of current Alzheimer's drug research is focused on therapies that target amyloid or other aspects of the disease process itself, aiming to actually slow or stop the progression. Disease-modifying therapies.
Okay, shifting gears to depression treatment. What about ECT electroconvulsive therapy? It still has quite a stigma. How effective is it really for older adults?
It's remarkably effective. For severe geriatric depression, especially depression with psychotic features like delusions, ECT should arguably be considered a first-line treatment. It's often much faster and more effective than medications in those cases.
More effective than drugs.
Often, yes. And interestingly, older age is actually associated with a faster and better response to ECT. One study showed a 62% remission rate in just 2.5 weeks for older patients with psychotic depression.
That's impressive.
Yeah.
What about side effects, like memory loss?
That's the main concern, yes. There can be temporary confusion right after treatment and some memory loss, usually for events right around the time of the treatment, especially things that weren't highly important or emotional. But clinicians use techniques like applying the stimulus only to the right side of the head, rate unilateral placement, to significantly minimize those cognitive side effects. It's much safer than its historical reputation suggests.
So the stigma might be preventing a very effective treatment from being used more often.
That's often the case, unfortunately. Patient or family reluctance based on outdated perceptions can be a barrier.
That leads us to psychotherapy. Freud, famously, was pretty pessimistic about therapy for older people, right?
Yeah.
He thought their minds were too rigid and elastic.
He did. But thankfully, modern research has completely debunked that idea. Age itself is absolutely not a barrier to benefiting from psychotherapy. Older adults can and do make significant changes.
And do they want therapy?
Many do. In fact, older adults often prefer talk therapy over medication, if given the choice. And the positive effects can be just as strong and lasting as drug treatments for depression and anxiety.
What kinds of therapy work best?
Cognitive behavioral therapy, CBT, and problem-solving therapy, PST, are very well supported by evidence. They're adaptable for older adults, even those with physical health problems like COPD or post-stroke recovery.
What do they involve practically?
Well, CBT helps people identify and change negative thought patterns and behaviors. PST focuses on teaching skills to cope with specific life problems. Behavioral techniques are key too, things like activity scheduling to combat withdrawal and depression, or graduated exposure to gently confront feared situations, like that fear of falling we discussed.
Makes sense. And what about mind-body approaches, yoga, meditation?
They're increasingly popular and showing real promise. There's good evidence, for example, that chair yoga can significantly reduce symptoms of depression and anxiety in older adults in care facilities.
Chair yoga, so it's accessible.
Exactly, and perhaps one of the most compelling findings is around exercise. Studies have shown that regular aerobic exercise can reduce depressive symptoms about as effectively as standard antidepressant medications like sertraline.
As effective as an SSRI.
Yes, with the added benefit of lower relapse rates after the exercise program ends. It's quite powerful evidence for lifestyle interventions.
That really is powerful. Okay, we've covered a huge amount of ground today on geriatric psychiatry. So wrapping up for our listeners, what are the big takeaways? Clearly, this is a field facing enormous growth due to demographics. We learned successful aging is really about psychological adaptation, not just staying disease-free.
Right.
Assessment is complex. You have to be a detective about polypharmacy first. And the good news is that treatments for common issues like depression and anxiety has many effective options, from meds and ECT to therapy and lifestyle changes like exercise.
And if there's one single concept to really grasp about aging, it's increasing heterogeneity.
Heterogeneity, meaning more variability.
Exactly. As people age, they become more different from each other, not more alike. Differences in health, personality, life experiences, resources, they all accumulate over a lifetime.
So a one-size-fits-all approach works even less well for older adults than for younger groups.
Precisely. Standardized guidelines are often less helpful. Clinicians really need to approach each older person as a unique individual with a potentially wider range of behaviors, needs, and responses than you'd typically see in younger patients.
That really underscores the need for personalized care. Which brings us to a final thought. Given how dangerous polypharmacy can be and how effective things like therapy and exercise are proving, how could we maybe reshape primary care to really prioritize these non-drug approaches before automatically reaching for the prescription pad, especially for older patients? Something to think about. Thank you for joining us on this deep dive. We hope this journey through geriatric psychiatry has been illuminating.